Here is an algorithm for vasopressor management in patients who are in shock. Of course, you're going to assess your airway, breathing, and circulation. Most of the time, patients get fluid right off the bat. Here, you have to determine whether patients are responsive or not responsive to fluids. If the patient is not responsive to fluids, norepinephrine is usually your first-line vasopressor, and this is discussed in much detail in the Vasopressor and Inotrope handbook. If the patient is responsive to norepinephrine, then you've got to figure out what is the cause of this vasodilatory shock. Is it septic? Is it after an MI? Or is it after cardiac surgery? If the patient is septic, you determine the source and you obtain source control. If the patient is not responsive to norepinephrine, then you have other agents you could look at, such as vasopressin, epinephrine, phenylephrine, or per this diagram, angiotensin II, which I have zero experience with. Of course, this is not the end-all be-all of managing patients who are in shock, but it's a good start. Hat tip to the authors.